Respected Chair, Dr. Amulya Sahu sir, and the entire management here. Thank you for the opportunity, and I'll be speaking on SICS in complex situations. So I'll just take you through a couple of scenarios here, and so there is no situation in which SICS is not suitable. Like, that is the reason why Dr. Boramani just always calls. I learned this quote from him that there are few situations where FACO can be is not advisable or it cannot be performed, but there is rarely a situation where SICS has to be avoided or contraindication. So so let us go through a few examples here. Now this is a posterior polar cataract. So in these situations, as we all know, there is a higher risk of having a posterior capsular tear, and of course we are avoiding hydrodissection. And one change which I have made here is I made an oval rhexis which is longer in the longitudinal area and then shorter from the side. Well, actually this is proposed by Dr. Kiranjit Singh for phacoemulsification, but I feel that you can very well use this for the manual SICS as well. Now, because we have got a longer exposure in the subincisional area, maneuvering the nucleus out of the bag is relatively easy. We don't do hydrodissection using two Sins cubes. It is just wheeled out of the bag. Now, when we are going to pull the nucleus out, there is a momentary shallowing of the chamber, and this is when the posterior capsular tear can happen. So this is what I experienced initially. That momentary, whatever shallowing is there, that is what causes your posterior capsular tear to happen. In this case, the anterior hyaloid was still intact. The anterior hyaloid was ruptured, but the vitreous prolapse had still not happened. We can clearly see this round circular thing, which is the anterior hyaloid rupture, and this is the posterior capsular tear here. And this is a stage at which you push in OVD to push back the anterior vitreous face and then perform posterior capsular rhexis. If the vitreous is already prolapsed out, and then you cannot do the posterior rhexis now. You have to perform vitrectomy and then perform the posterior capsular rhexis. But if you are still, the prolapse is very minimal, you can push it back with the OVD and then perform the rhexis. And then you're going to perform the anterior vitrectomy. The reason why we need to perform the rhexis earlier is because it's much more easier to do it in an eye which is not evacuated of vitreous, because vitreous gives us the support. If the eye has become soft, then obviously we can't, it becomes a little bit tricky to perform rhexis. And when you do a posterior capsular rhexis, inflating the bag and placing the lens will be safer. Otherwise, we are going to enlarge the rhexis when you're trying to maneuver this lens into the bag. So because we have got a very strong rhexis, you can place the rigid PMM lens into the bag and still don't have an extension of the rhexis. So now my question was, can we prevent this posterior capsular tear in these PPC cataracts? Because this was the step in which it actually happened, that momentary shallowing. So how can we prevent this? So I was thinking that this is another dense cataract with a posterior polar cataract, and there's a reason why I chose to do a manual SICS over the phacoemulsification. We performed the same steps. You have a large oval rhexis, but one additional thing which I did in this case was, during the delivery of the nucleus, I didn't want the chamber to shallow. At that stage, I thought it's better to maintain the chamber using an AC maintainer. This was, I'm using it off late. I've never used AC maintainer before, but off late I find at this stage it is still off. It's not on now. But when I'm just removing the lens, that's the time when the AC maintainer is turned off. So here, another point here, we don't want a very high hydrostatic pressure. So if you keep an AC maintainer and keep the bottlet at 90 centimeters, you are going to blow out the capsule. The function of the AC maintainer at this stage is just to ensure that the chamber does not collapse. So it is kept at 40 centimeters or 50 centimeters. If you overfill, you are going to blow out the chamber. So you don't want the thing. So bottlet is kept at 50 centimeters and it is on only at this stage when you're trying to prolapse the nucleus out. The traditional way of maneuvering the nucleus out with an AC maintainer is to just press on the scleral lip and it has to pop out. But that cannot be used in this posterior polar cataract, because that increased hydrostatic pressure itself can blow out the posterior capsule. So you're using a phaco sandwich technique with OVD, but you're also turning on the AC maintainer. So this is the stage at which the AC does not collapse, and that's the reason why I believe you have a better chance of preventing the posterior capsule rupture. So then the next of the steps would be as usual. It's nothing much in this case. So this is something which I've tried and I find it very helpful. So maybe there are many pioneers here who have used AC maintainer much better, in a better way and in longer way than me. So, but I find this is helpful, which is what I've been doing for the last maybe a year or so. So during this step, it is off, and this is done under dispersive OVD only during extraction of the nucleus. If there is no AC maintainer, the chamber is going to collapse at this stage, but you're going to keep the AC maintainer on, and this would prevent that the collapse of the anterior chamber. So I think with that, to save some time, I'd like to, do I have some time, sir, or is it over? I think my time is up. So thank you for the opportunity, sir. Thank you so much.
Thank you, and compliments on your, very first-class videos.
Thank you, sir. Thank
to
you.
show a capsular tear consistently is not easy. So
Thank you, sir.
well done. Thank you.
Sir.